वो लाइव क्लिक कर दिया है मैंने।
Um,
Good evening, everyone, and I am happy to uh, invite and thank Dr. Amit Sethi to be on today's Haryana chapter AIOTA page program. I and Amit go a long way. I know him since 20 years probably. He at that time was a clinician. He had and he was very much working in the Indian context. So in that sort, and adding to that the current profile and being in US since many years now, he's the right person to talk about today's topic: evidence-based practice, is it a myth or a fact in occupational therapy? As clinician, I know that all other clinicians also feel this, believe it, they talk about it, discuss it. May not be we may or may not find the same topic in our textbooks or journal articles, but we know that it is a constant question and a deliberation among all of us, whether clinicians and practitioners can take anything out of this evidence-based practice kind of a concept. So let's discuss with Amit along with our few invited people. Mr. Anil Singh is here. Mr. Zahir Abbas is here with us, and we'll see how and when we can also ask them to take up any kind of questions. So welcome, Amit, once again to this program. We have already shared your profile in detail with all of us. I'm sure they must have your profile in front of them. They know you anyhow. Yeah, you have done a course earlier on the same kind of topic on protocol development and systematic assessments. So welcome to you, and if you want to start with few words, or else I will start with the questions.
sure. Thanks, Manish. Yes, as Manish said, he and I go a long way, and we have been good friends for a while, and not only professionally, but also on a personal level as well. And then today's topic is actually quite dear to me because in India, when I did my bachelor's. I completed my bachelor's in occupational therapy from Manipal, and then I was looking for furthering opportunities for studying and understanding the science of occupational therapy actually, and that's what pushed me to look for opportunities outside India, because at that time we did not have a lot of um, it was still growing. I wouldn't say it wasn't there, but it was still coming up at that time. But now I know the field and the profession of occupational therapy in India has advanced significantly. There are a lot of PhD professionals in the field, and are many who are seeking for higher advanced training beyond the master's degree as well. So this is an important and a pertinent topic for the field of occupational therapy, especially in the Indian context of practice for occupational therapists. Thank you for inviting me.
Sure, Amit. So, Amit, let me start with the very prominent and important question. You know, evidence-based practice is a very common term. It's a term that everybody would have probably read about it, defined it, learned about it a lot, especially during graduation, post-graduation, PhD course, whatever academic course that they have taken up. All occupational therapists would have seen this term. And we know that evidence-based practice is a term which is common with academicians when they take up academic roles. It's a very common thing that they that they talk about it, and there are a lot of times conferences and workshops talk about what is out there as a proven or as a practice that can have that has some evidence or not, including some of the most prominent approaches that are used in pediatric OT. However, do you think it holds relevance for the clinical field, for the clinicians, for the practitioners like me, who are full-time practitioners mostly, rather than into academic roles? What do you think?
That's a great question. I'm glad you brought that up. Absolutely. If we let's dissect the term evidence-based practice. So evidence means a proof, right? Something that there is a value or there is a proof in that something works. And the word practice by itself, in the term EBP or evidence-based practice, means clinical practice. So the definition, the most common definition of evidence-based practice, which is the most layman definition used for a general clinical practitioner, is or a therapist, is the ability to apply or translate research findings that somebody, a researcher, has spent numerous a number of hours in generating that evidence. How can a clinician then use that information and then apply or translate in his or her daily practice and make informed clinical decisions with that? So it is this ability to translate all that information from the research articles, and then how can I then apply it in my day-to-day practice as a clinician, as a therapist? So that is what the evidence-based practice means. And by the definition itself, it holds relevance for a clinician or a therapist, right, in that context. So absolutely, there is no doubt about it that this is only used to be used for academicians. Academicians generate evidence, I would say. Clinicians use that evidence, become a consumer of that evidence, and use that in their day-to-day practice. Not to say or deny that clinicians cannot generate evidence as well. They can, however, it requires extensive training and it's a very systematic process. And if you are working as a clinician only, as a therapist only, then you may not have the time to do that or the training required to generate evidence. However, in some cases, we do see that it does happen as well. So it's for both academicians as well as practitioners, clinicians. The most valuable, like the most merit it has is for clinicians, I would say, with that. So absolutely, we should not doubt that this is a term that's only supposed to be used in a textbook for and shy away from using it with that.
Right. So, I mean, like you said, it might be of the most value to clinicians. So let's start with then, again, a next very relevant thing. So suppose I'm a practitioner, and like me, maybe the few others who have joined today in this discussion today, or the viewers would be full-time practitioners rather than much of a role with the academic. So if I'm a practitioner and I want to incorporate evidence-based practice in my daily practice, I intend to do that. Where do I start from?
Okay, that's where the $1 million question comes, right? So where do I start? And the I think the like I am an assistant professor, and in my role as a faculty member here, we we often teach this. And then the main thing what we need to understand is that where I see the gap is like, okay, a researcher has done this work and has published in their professional journals or presentations at conferences. The next step, which is now I need to bridge the gap and make it more simpler from that evidence that has been generated. The next step is how can I use it or implement in my clinical practice? Because what happens is a research setting is a very controlled setting with that. I do a lot of clinical trials, and as part of those clinical trials, we make sure everything is in a very controlled setting. I have the control for my patient, I have the control for the participant, I have the control, I'm controlling for the environment, the therapist who I'm training, the research staff members that I have, everything is in a very controlled position, environment with that to say. However, in the clinic, that's not the case. In the clinic, there is so much variability and heterogeneity. with this, right? And so um, there are a lot of factors that can influence the efficacy or effectiveness of the intervention or the treatment that you are trying to use, that the evidence has been generated for with that, right? So the issue comes in, how do I translate this in my clinic as is with that? If I directly try to lift something from a research article, I'm sure people who are attending this or right now and who are hearing this now on Facebook or in future, if they would be listening, they can easily attest to that it is very difficult to directly use a research protocol and intervention that has been published in a paper, um, and directly implement in your clinical practice because of these factors which are beyond the control in our clinical practice. So to give you an example, I work with patients with stroke who have upper extremity impairments, arm and hand weakness, and my specialization is to develop novel interventions and technologies to improve the upper extremity function after stroke. The most commonly used or the most effective intervention to improve arm and hand function after stroke is constraint-induced movement therapy, where you put a mitt or you constrain the most affected hand, or now it's also, I mean, instead of using the word constraint induced therapy, we can also use repeated task practice. But the general idea is the same. You want to encourage the movement of the weak hand over and over again for multiple repetitions. And the amount of training or the amount of treatment that has been published in the literature is 6 hours a day with that, with the therapist. That's a lot of time. I don't think in the US context, for sure, the patients don't get that much time with the clinician. I don't think even in India, it's possible to give that much time to a patient or a child for that matter as your client in a clinical setting with that, right? So that you can see directly there's a breakdown. How do I then apply? Then the therapist is like left puzzled, that when confused. Okay, now they did this in their research article, but if I don't do this, how can I then adapt this to my setting with that, right? So that's where the things start happening. There's a disconnect with that. And so what we should be looking for is something called as clinical practice guidelines, CPG, and based on and a lot of diagnoses for rehabilitation, they have developed these clinical practice guidelines. However, again, some of these clinical practice guidelines may only be guidelines. They may not give a very specific protocol for you. So there is a process of how you need to develop a protocol with that. And the first step in order to do that is to go back to the basics. So so I can see that as this is a two-step process. So the first step process is that I need to go back to my basics in terms of my anatomy, physiology, cognitive science, psychology, neuroscience. So we need to go back to the theory of occupational therapy, the tenets or in occupational therapy. So I think if you think about, like, we can take an example of pediatrics, since a lot of people in India are practicing in the field of pediatrics. Sensory integration therapy frame of reference, right? So if you look in the classic textbooks, you would see initially there's this tenets that they talk about. Okay, what is the theory and the theoretical principles, which are the ones that are being used to develop this treatment of sensory integration practice. If I directly just apply um, the methods of treatment that have been developed without focusing on how they were developed and which theoretical principles were used to develop them, I would always end up in a situation where for some or few sessions, the client or the child is going to respond to me as part of my intervention. However, very quickly, I will find out that no longer this treatment is working. And then I'm stuck there, right? Because I have not provided a rationale for my treatment. with this, and that's where the issue and the breakdown happens. So you need to go back to the basics, look at the theoretical principles. What are the guiding principles? Um, and match them with the impairment or the symptoms that you're seeing with your client or child, and then they'll come up with the methods of treatment with that. So it's a very systematic process. So this is evidence-based practice in itself here, because now I'm looking at the principle, and then I go and search for evidence. Okay, was this used in a practical in this population with this client? And often what we teach our students is called a PICO framework, PICO. P means population of interest, I means intervention, C means a comparison, and O means outcome. So if you think of an example, uh, and I'm not a pediatric therapist, no longer a pediatric therapist. I used to work in pediatric a long time ago, but I'm going to make up an example, and you can correct me if I'm wrong. So let's see if we pick, if the behavior that I'm trying to correct or improve is sitting postural control, for example. Okay, so I can say that, okay, if I'm going to use NDT in children with cerebral palsy, so my P stands for um, population, which is children with cerebral palsy. I is intervention. Now I'm going to see which intervention. So let's say I want to take NDT, the neurodevelopmental theory, with that, right? And then I'm going to compare it with something else. So some other intervention could be strength training, for example, strengthening. So I'm comparing the efficacy of NDT versus strength training, and O is the outcome. Outcome is my postural control, the ability to balance with that. Okay. So we have to use something like this framework, and then, but again, connect it back to the theory with that. And then from there, you use this framework of PICO and then look for articles with that. And so that's the first step. The second step is how to understand the articles, right? So depending on your level of comfort and your training with that, it sometimes becomes challenging to read a research article and also um, interpret the evidence from that. And so there are several tools available, and I'm going to share my screen here so you can, the one that I like, one of the most to use is this one called can you see my screen?
Yes.
So it's called the Critical Review Form for Quantitative Studies. Similarly, there's one for qualitative studies as well. So if you just Google McMaster University Critical Review Form, you can find this. And this is in McMaster University is in Canada, and they were one of the pioneers for this concept of evidence-based practice, and especially how to use it in rehabilitation context with that. So this, as you can see here, this form guides you to dissect a research article and then come up with what is the most important information that you can gather from there, but also identify what is the effectiveness of that intervention with that, right? And so it talks about these different concepts. It goes step by step for the across the article, and then you can dissect it in that. Now, of course, this requires time and knowledge how to do it, right? And so um, I usually teach this oftentimes to our students here, and then I'll be happy to conduct a workshop on this as well in future for people in India. And I'm sure most of the people might already be getting this information, but as I mentioned, the disconnect happens is that how can I quickly use this information and then move from not just being stuck in the field of theory, but actually translate it to my clinical practical knowledge with that. So I know I gave a long answer to your question, but the two most important points are, first, go back to the basics, and then
Mhm.
connect it to your foundation. And the second is use a framework like this with Pico, and use a tool like this, and then identify, dissect the evidence with that, and then that's where you would start.
Sure. It's great. It's great to know that there would be a program in future coming up on understanding or getting the knowledge about incorporating evidence-based practice into the clinical practice. So beyond the knowledge part or beyond understanding how to do this process, there are two major barriers when it comes to practitioners. And one is about time and one is about resources. So, the practitioners are really stressed. They always say that who has the time? So despite all the good intention that they have, despite all the uh, important, valuable work that they are the ones who are, working with the population directly in a larger number than the
Mm.
academicians and researchers. However, they are really stressed, and that is true. In a busy clinic, you hardly have the time and the resources to do this. So tell us if there are any ways, any solutions, if they wish to do some data-driven evaluations and treatment. What do you think what they can do?
That's another good question. Like the time and the resources are always going to be limited with that, right? With that, and that's not true only in the Indian context. It's also true in the US context as well, because the healthcare is driven by insurance here. And that makes it another additional challenge a lot sometimes for people to to guide their clinical practice with that, and adds another level of constraint in terms of time and resources with that. So how can we become smart and then take it to the next level and incorporate this? So the first thing, as I mentioned, I'm going to again share my screen here, and then because there's a framework that we usually teach for this, and then here's a framework for clinical reasoning with that. So if you can see my slide. So this is something what we often advocate to use in a setting, and then the it's basically divided into two parts: the problem sensing and the problem definition and the problem resolution. So usually what happens is when a patient or a client comes or a child comes to an occupational therapist, we directly jump into this evaluation part and then we get into this treatment. However, there's a lot more that you can do before the patient comes into the evaluation with that. There's a component of screening and a conceptual model development with that. And this is, if you would appreciate how this ties into what I was telling you earlier, going back to the basics and foundation. So as soon as the patient walks in to your clinic, right, we should always be thinking about using our observation skills and then thinking about screening. And instead of doing a whole evaluation, divide or strategically use our evaluation so that we develop something called a screening checklist, in which we often do here, so that you can then directly come to the point or come to the target of, okay, which aspects of the body structure, function, or activity and participation, and I'm using the terminology from ICF, which is the International Classification of Functioning and Health, given by the World Health Organization in early 2000s. And so using that and then coming up with these checklists with that, right? And so I can then quickly identify just by asking few questions or by observing the behavior of my client or a child, that where is the problem? And then I come up with some hypothesis around that. Okay, that this is the kind of framework that I should be using generally with that. And then I go into the evaluation with that. So so instead of doing 10 assessments, which I don't have time, I can then avoid that just by doing 2 assessments or 3 assessments, a more targeted and a personalized way of assessing my clients with that, right? And so, and that way, as I'm connecting it back to the basics here in the foundation of the frame of reference that I'm going to be using, I am also, that is how where the theory is driving this, right? And there is a good likelihood that the intervention that I will pick up is going to work most of the times with that, right? And so this process, we need to be very diligent in order to do this. And um, in fact, the model that is being used in the US right now is in the primary care hospitals or in the primary care uh, doctor's office. So for example, if the I know with older adults and also with pediatrics, we can think of an example. So like an older adult, somebody over 65 goes for a regular checkup, which I know is another thing which doesn't happen in India, right? No one goes to the doctor as part of their annual evaluation or checkup. I struggled that with my parents as well. But until they moved here to the US, now they're the primary care physician, their primary doctor asks them to come every year for a checkup with that. So as part of that checkup process, they do a screening for rehabilitation as part of that. So rehabilitation has been integrated or is becoming integrated. It's not integrated yet, but the goal or the hope is that rehabilitation is getting integrated in the primary care with that, with the first doctor that you see. With that, the goal, they do a lot of screening and then they can refer for occupational therapy services right there with that. And so they can do some of this. However, even then, if somebody has done that, but we need more specific screening for occupational therapy in general also, right? And so this is important. This is very important. This would save a lot of time with that. So I hope this was something that you were trying to ask me here, I'm guessing, that how can I'm streamline my process of evaluation, right? And make it more efficient with that.
Right. So let me continue the discussion, although you might have answered a little bit about this next question, and that is about we all practitioners feel and know, especially in India, we know that the assessment tools and scales, we know that we are very fond of them. We want to use them. There's a big intention about it, but they are very, very costly. So,
Mm-hmm.
we have to import them, and then, there are some details in it. We would like to put in some time in it, but the cost is really an hindrance. So I wanted to ask you if you can suggest anything that the private practitioners can do in a cost-effective manner to measure and do something in a standardized manner.
Sure. So I'm going to, let's see. So I think there are 2 parts to this question. The first part is are there standardized assessments? And by the way, let's go back to the definition of standardized assessment. So what is a standardized assessment? A standardized assessment is the one which has good reliability and validity, good psychometric properties for the assessment, which means that if the assessment is administered in a standardized way, I would get reliable output, right? In what I'm trying to measure. So oftentimes what happens is, and here also we've seen that there are 2 components to the standardized assessment. the first is, if you have standardized assessment, then you use it. But if you don't have the standardized assessment, then what do you do with that, right? Or even in the first one, you know that I want to use the standardized assessment, but the standardized assessment is very expensive with that, right? That's what you were trying to get at. So again, I'm going to share my screen, show a website that many people may not be familiar with. And let's go to this website here. This is a website from Shirley Ryan Ability Lab, um, sralab.org/rehabilitation-measures. So if you Google this, you will find that there's a database of rehabilitation measure. This is a rehabilitation measure database, and this has more than 500 clinical assessments there, okay? Now, how do I find out whether this is free or not free, right? And so, and what you can do is you can filter by a lot of these filters here. So assessment type, you can see what kind of assessment you want. Patient reported outcomes performance measure. Patient reported outcomes meaning that it's a self-report measure that you're asking a question to the patient or the caregiver. Child or a parent. Performance measure is something that you're measuring directly, like range of motion or strength. Area of assessment, there are all kinds of areas of assessments that you can think about. It's a very comprehensive list. The most I look at is this upper extremity function. You can look for swallowing. I mean, there's an endless list here. Infant and child development, you can see. Then population, you can then, based on the population that you're interested in, you can look at, you can filter through. And then the other thing is here, body part. And the most important thing, which I like, is the not free versus free. So let's just click on free assessment and see what happens. And we see that out of 500 assessments, more than 500 assessments, 370 assessments are free. This is without the fact that I selected any assessment type, a population, or anything like that. So there directly you can see that there are a lot of assessments which are free. And like this kettle test, for example, if you click on here, you will see it'll give you the research article where you can find this information. Like it gives you the details of the instrument, the assessment, the condition for which it is being used. It has been validated. It describes the test as well, the number of items, the age ranges, the ICF domain, and also gives you reference here that you can then go back and look on PubMed, for example, and get the test in more detail. That right? So that's one way of of finding the assessments which are cheap, I mean free and not expensive. Now you have to invest some time in understanding and learning them and using them. That's a separate thing. The other question happens is, what happens if there is a construct that I'm trying to measure and I don't find any standardized assessment, right? Then what do I do? Should I just let go or directly jump into the treatment, or do I still need to evaluate, right? I think I can see you nodding. That must be your question that you must be thinking as well. Seems like that's a very relevant question. So absolutely, we have to measure. There is a very famous saying that if something is not measured, I don't know, I cannot track whether there's any change or improvement happening, right? That. So if I'm not measuring, I don't know whether the intervention that I'm doing is working or not, right? How would I convince the client? How would I convince the caregiver, the parent or the child? How would I convince myself? Forget about them. I need to sleep at night thinking that what I'm doing as a clinician there is value in that, right? And I'm satisfied with my profession, the work that I'm doing. So I need to be convinced of my outcomes with that. So we need to make sure that we are measuring everything that we're doing. Yes, I know there is time constraint, but there are methods of how to do it using Microsoft Excel, something like that basic. We can measure the frequencies of a behavior that you're interested in. So let's pick an example. Why don't you give me an example in a pediatric setting, and I'll try to tell you what we can measure in that.
Yeah, maybe whether the child's behavior in the classroom improved or not after sensory integration treatment. Did the child actually improve in his classroom behavior?
Okay. And how would we, now let's go back and then think about how would we measure this? So we need to think about this. This is a good example, but it's still pretty broad, right? Child's behavior. What is the behavior that we're looking at? Let's say we are looking at the sitting
Maybe
tolerance.
sitting down. Yes, sitting
Yeah,
down in the class.
sitting
Yes.
tolerance. Let's say if we're looking at sitting tolerance, right? And so for sitting tolerance, if there is not a standardized test, the most objective way that I can think about, I can measure is the number of minutes that this child is sitting, right, in the chair and paying attention to the teacher. So I can start in every session that I'm seeing this child for, and what is the typical length that you would measure this? Let's say 2 weeks, 1 month, something like that, right? That
Yeah.
you
Yeah.
would
Yeah.
be
Yeah. Yeah.
looking at with that.
Mhm.
So 1 to 2 months. So every session that you're observing this child in the classroom, the teacher could simply jot down what are the number of minutes that this student or this child is able to tolerate sitting behavior with that, right? And you would see quickly that, and you measure it before starting your intervention, and then you measure it throughout while you're giving the intervention, and then you see whether there is a change in this trajectory or not. So in this instance, you would see that we want a greater increase, right? The expected outcome is more sitting tolerance with that. In some instances, you can expect a decrease in the behavior with that, right? So with that, but in this case, it is you want an upward trajectory going up and increase with that. So then you can plot using Excel that, okay, um, how do you what is the change that is happening with that. Now again, it sounds simple, it is simple, but you need a little bit of training in how to do this. Something using single subject design analysis that I teach here, that we can use to do that. And I know we did a workshop on this last year at the beginning of pandemic, and it was quite well received. We'll be happy to do one more round of that, and see if there's enough interest for people to learn this technique. But it is systematic, it's easy, and then you can look at yourself, what is there's a change that is happening over time. You can look at you can show it to your client. If it's a client who's adult, if he or she understands, then you can show that, okay, this is the change that when you first started and now where you are with this. And you can even show it to the caregiver or a parent with that, right? Because that will then make sense. So absolutely, you have to measure. There's no reason to get by it or avoid it with that, because if something is not measured, as I said earlier, we cannot track it, that and cannot be satisfied.
Sure.
So
Sure.
these are
Sure.
some
Sure.
easy ways of incorporating evidence and assessment in your practice.
Sure. So wonderful input, Amit. I would now like to invite some of the our people who are sharing, who are today with us, to ask a question directly to you. And I would
Sure.
first like to invite my friend, Mr. Anil Singh. He is a program manager uh, in an international NGO, and he would like to. I would like to invite him to ask his question. Go ahead, Anil.
Yeah, first of all, thank you, Amit. It is really insightful listening you. And though actually I do not belong to occupational therapy fraternity, but I'm very close to you all. And I do believe that these challenges, whatever persist related to evidence-based practice, is quite common, whether it is occupation therapy, physiotherapy, and prosthetic and orthotic. So this
Hmm.
one, my question is that. To you that how we can ensure the implementation of evidence-based practice, because what I'm hearing that there is so much challenges while it comes for the implementation of evidence-based practice. So that's what one thing we can do to ensure the implementation of evidence-based practice in Indian context particularly.
So I'm going to ask you a question. That's a great question. I want a little more clarification in terms of implementation, because implementation is a very broad term. If you think about what do you mean specifically by implementation? Implementation at the level of the therapist or the clinician and their team, uh, or implementation at the level of understanding and training of how to do implementation, where specifically you were asking, or both?
Yes, here I meant for the implementation while we are treating the patient, while we are formulating the treatment particularly for the patient as a clinician. So
Hmm.
this one, how to ensure that we all are following our clinician is following this latest evidence-based practice.
Right. So as I mentioned earlier, there's something called as clinical practice guidelines, and if you don't have it, you can generate them by looking at the evidence. The the main thing, there are two components to this implementation piece. Then that was the first question, I think, which Manish asked, and that is where the most common background, I mean, not background, the breakdown happens with that. The first thing is that that how you want to, when you're trying to directly lift something from a research article and start implementing in your clinical practice, that's where the big breakdown happens. And the first thing you have to think about is training your staff with that. The training for the entire team, whether it is one person or more than one person, that person needs to be trained efficiently and effectively in order to implement this. If it's just one person, it's easier. However, as you can see, if it's a bigger center and you have 5 occupational therapists, or 5 prosthetics and orthotics and physiotherapists and other rehab professionals, you have to make sure that everybody in the team is following the protocols in a consistent way, and you are implementing in that. And it is a topic beyond the scope of this live session, but I'll be happy to teach how to do that, because that is something that we do in a research environment. When we do training for our therapists. So like when I have done randomized clinical trials, we I have developed the treatment myself, but now I am not the one who is implementing the treatment. I have trained 5 other therapists to do that. But I want to make sure that each therapist is doing the treatment in the exact same manner with that. So I need to come up with a packet of standardizing this entire treatment protocol for them, right? So that ensures consistency and reliability, and it reduces the error in how we are implementing this treatment. So is that something that you were trying to ask with your question?
Yes, Amit, thank you so much. I think I I will get back to you this after the session as well, and actually through
Sure.
Manish, because I'm really interested to actually go about it, because I feel that evidence-based practice is really important, and this is the time we need to take it forward. So this one, I may need your help in this regard. Thank you so much, Amit.
Definitely. I'll be happy to discuss it further. Thank you.
Thank you.
Uh, we have one more guest with us. I would like to invite Zahir Abbas to ask his question. Zahir is in Kolkata. He's a clinician. He works primarily with children, and is a very sincere learner, I would say. Zahir, your question, please. Zahir, you there?
He's on mute.
Okay, I'll try once to. So meanwhile, we are waiting for Zahir to try and unmute and see whether he's available. Uh, Amit, another basic question is, what are the benefits of evidence-based practice? Why at all, anyone should think about evidence-based practice beyond, again, more for the sense of practitioners and clinicians? Why should they even think about evidence-based practice? Probably we should have started with this, but again, it's the right time to kind of reiterate.
Right. So this is again the $1,000,000 question. Why should I care about evidence-based practice, right? My work is going on. I'm fine what I'm doing, but why should I push myself to strive for this? So I think the main reason a clinician needs to do evidence-based practice is there are multiple reasons to this. The most important one is to make sure that their outcomes are the best outcomes, right? If you're in a private practice, for example, you want to make sure that you have the most number of patients coming, your clients coming to your facility, right? Your clinic. That is how you will generate the most revenue and get the most money for your clinic. Isn't that true, right? That's what everybody was looking for that perspective in that, right? How can you ensure you get the best outcomes compared to another clinic with that? You will only get best outcomes if you are doing not only the most cutting edge things, but also the things that have shown that have worked, right? That because what would happen if you're not doing something which has the most evidence and you are not in the capacity to generate that evidence because you're not a researcher who's doing this and you don't have time to do that, you are mostly interested in applying this into your practice. What you need to do is use this evidence in your practice, and as you do this, you will see the shift in your the paradigm shift that will occur in your clinical practice. A lot of you'll start seeing new referrals, and you start getting specialized and using the systematic approach of you going from the theory to the outcome of interest there, right? And that is how you will get the most benefit with that, using that systematic approach, which will then allow you to see more patients and more effectively and efficiently as well. The primary reason, I think, I'm sure this has happened. It used to happen with me when I used to work in the clinic, but a lot of it is still would be happening. Patients or children are being brought by their caregivers or parents, and they come for a few sessions and then suddenly they drop out, right? And then you wonder what happened with them, with that, right? And so and then they might say, oh, this center, we are not getting what we want, because initially they start looking at the improvement, but now something has stopped. So this ability to see that, okay, where is this disconnect that is happening with that, right? And so that is one of the direct benefit that you would see, that you would increase your clinical practice, and there is no reason or doubt from the word of mouth that it would spread as well. That right, that you are one of the best clinics in the town or in the country for that matter, because you're using evidence to support your outcomes with that. That is, I think that's the biggest benefit for this, that if you are working in a hospital or in a center where it's not your own center, why would you still care for evidence? Well, for the same reason, your employer, the main person in charge of that facility, should be the one caring for this, because again, they can improve their outcomes they can get more patients and treat them in an efficient and effective manner with that. So I think that is the biggest benefit. And as a clinician, I would sleep satisfied, right? That is the most important thing. I think when I go back to bed every night, I think about, okay, how did I make a difference in anyone's life today? And knowing that I'm doing something right would give me more personal gratification and satisfaction. So I think that the number of benefits is endless, but just to reiterate a couple of them here.
Sure, sure, Amit. I'm sure. So I think Zahir is back with us. Zahir, I would ask you to unmute yourself and ask the question. Right? Yeah, yeah. You are on. You are. If you could start your question, then we'll let you know if we could hear you.
Yes, sir. Good evening.
Hi, good evening. How are you?
Hi.
Absolutely fine. By grace of Almighty, we're doing well.
Good to hear that.
Thank you for your nice deliberation, sir.
You're
Sir,
welcome.
one question from my side: how to be more quantifiable, more objective in our clinical practice beyond research oriented things, like beyond research oriented things, how we can make some useful tool like pain analog scale, like 0 to 10, how much you feel your symptoms. So how can we have something in pediatric practice so that we can have a setup, like we can within 5 minutes we can come up with the, like earlier it was like this, today is like that, and we
Mm-hmm.
can quantify those things. So
Right.
how to
So
come up with such ideas?
yeah. So I don't know if you were listening. This is the same question that Manish had asked me, but you asked in a more clinically relevant way, I would say, right? So when Manish asked that, can I use how can I use standardized assessments or a standardized approach when I don't have um, tools available to me, right? With that, so using the behavior of interest that you are interested in to measure, right? So for example, we were giving the example of sitting tolerance, but we can use the example of pain here with that, right? With that, if you are interested in that as a construct, and you have to go back and think about what is the construct that I'm interested in and how I'm going to measure it. Now, in order to understand that measurement piece, you need to know the basics of measurement. There are 4 types of scales. There's a nominal scale, an ordinal scale, an interval scale, and a ratio scale. You need to know which type of scale is the one. And don't get confused when I say the word scale, because it's not a standardized scale we're talking about. You need to know which type of construct, where my
The
construct falls
statistics, right?
under these 4 categories. Say that again.
That is statistics, like how to statistical data, like that is the data, how we
Yeah,
collect the data, types
yes,
of
how we
data you are
collect
talking
the
about.
data. Exactly. Yes, exactly. How you collect the data. That is very important to understand, because unless you understand which type of metric that you're using, accordingly, you would quantify it with that, right? So for example, let's give an example of the sitting time. Sitting time, the amount of time is a ratio scale. Time is a ratio scale here, and so I can measure in the number of duration of time with that, right? With that,
Right.
if on the other hand, if I was interested in how many cues do I need as a teacher in the classroom, how many cues do I need to give to this child to make sure that he or she doesn't get out of the seat in a 1 hour session with that. Okay, so that's number of cues, 1, 2, 3, 4 with that. So that becomes a different level of, that is um, a more interval kind of an assessment. Not an interval assessment, yeah, we're looking at more ordinal assessment there, sorry. And then we shift from that. ordinal, nominal in that way, and then we move to an interval with that, right? So knowing this, where is the how the construct is being measured, accordingly you will use the analysis in using basic Excel function. And we actually did a workshop on this last year in June, July, I believe. Um, and seems like at the end of this, I'm thinking that there is a growing interest in this again. So it would be valuable to do another one of those. It was nicely attended, and I learned a lot while teaching. That's why I enjoy teaching. That it gives me the thrill to teach. Also, I like it, but also helping people like you in using these concepts in your day-to-day practice. Is that right? So I know it's in this small amount of time that we have, it's a little challenging to explain this, but I think Manish has your information. We can get back to you on that. Um, right.
Yeah.
Hope this is
Thank you
what
so
you were
much,
trying
sir.
to get out,
Thank
right?
you.
Yeah.
Yes, sir. Definitely.
Thank you.
Thank you so much.
You're welcome. Nice question.
Thank you, Zahir. Thank you, Anil. And I think, Amit, we should come to a conclusion of today's discussion. Of course, we would want to explore this topic and the process that we talked about, the knowledge and information that we talked about, connected to converting evidence-based practice as one of the methods or one of the practices to be used by practitioners as well, especially about practitioners and clinicians, especially what Zahir said. How do I know quickly,
Mhm.
like a visual analog scale does to pain? What do I do to quickly assess what am I doing in my and what am I gaining in my daily practice with my children? I think it's a very, very important question, because parents are of course looking for that. The therapist himself is looking for it, because he should know if he's doing the hard work, if he could quantify it, and if he could himself tell to himself and tell to others and tell to the mother or to the parents, most importantly, that this is what it looks like, this is what it looked like before, what it looks like now. I think that would be a great value addition to the whole field, to the whole profession, not just to OT but to so many other rehabilitation professionals across, working with so many, I would say millions of children in India are receiving
Mhm.
therapy now, and therapy has now grown. There are a lot of therapists available. There is an awareness for therapy. There's no dearth of people looking for therapy, but of course now it is we should be able to take therapy to the next level of being reflectable, where we could explain, quantify, describe, put it in a report, formatize, and be make it more and more presentable and
Mhm.
objective, for of course, for sure. So having said that, I know that we have discussed about a course that you should plan around this topic. You should plan something there where therapists, professionals can come together and learn all these things that we discussed today in detail, to the level that they, after the completion of the course, they should be able to go to the next day to their clinics and be able to incorporate what they
Mhm.
learned from the course, and whatever the gaps earlier were, or which we discussed today as well, the gaps and the new learnings should be implementable from the next day that the course is over. So I'm happy that you are in fact considering, you are planning to bring in that course. I would be very happy to coordinate, facilitate the people to make sure that they have this information. Uh, uh, but if you would like to share some information about the upcoming course, please do that.
Sure. So I think the course that we did actually in June, July, as I mentioned earlier, we seems like there is a growing interest for that again from the questions that were asked today from session. So I did in that course. What we did was it was an 8 session course. spread over 4 weeks. The whole purpose of the course was to do um, the outcome was that, okay, as soon as you're done from this course, can you take this immediately and run with this in your clinic, right, and implement it in that. And the whole purpose was to develop this mindset of how can I use standardized measurement techniques in my clinic, make it more data driven, my practice, and develop more data driven clinical protocols with that, that are evidence based and data driven with that. So um, I'm going to think about what worked well and what did not work well for that course. I know we asked for participant feedback as well. I'm going to look into that and then see how we can fine tune and refine that course more. So we can offer it again from that perspective, and I do see a need for that. And the the main we limited the number of participants to that course. I think was 30 at that time, but I think we can go up to 40 at the max. It's going to be very challenging to go beyond that because of the number of time that we have. And we we the main, I think one of the courses that I actually designed in that way, because I wanted a course to be delivered in a one-to-one manner, which is hands-on and is interactive with that, right? And so you have the ability to pause me during the lecture and ask questions. And then we did some assignments together in the class. It was a very discussion-based course. With that, we use the feature of Zoom with breakout rooms, and that helped us to divide in groups among team members, and then participants were able to work together in a group and then come back to the main room and present their findings with that. And using that framework um, allowed that more interaction with the course, which is where I think the drawback happens when you go for a workshop. In my experience, and I've seen that they dump all the information on you, and then after that what happens is you don't you are stuck there. Okay, how do I implement this in my clinic, right, and in my clinical practice? This, I don't know where to start. So that is where I came up with this idea that, okay, we don't want that to happen. Rather, we should want the end goal should be that you should be able to do this at the end of your clinic, at the end of this course, and then go back into the clinic and then start implementing that. So in order to facilitate with that end in goal, keeping in mind, the sessions were interactive with that. And there were inbuilt times where there were gaps with work assignments, so that would allow you the opportunity to explore this in more detail with that. So yeah, let's think about that again, and I can go back and review the feedback and see what's the fine tuning and refining the course with that. Yeah.
Sure. So with that information, and so it's exciting that we would be able to come up with another course and on the same lines that we did before. It was absolutely an amazing experience last time. There were so many very experienced people and professionals who had participated, and I'm sure they were very happy about the takeaways that they got from that course. So I think we have taken enough time today in this discussion, and we should be coming back to the Haryana chapter page next week again with some amazing speakers. And we thank, on behalf of Haryana chapter of AIOTA, we thank once more to Dr. Amit Sethi for giving us some time. It is his very early morning back there in US, but thank you so much. And we will bring in the details of the course.
Thank you so much, and it was nice talking to you, Manish, and catching up. And thank you, Zahir and Anil. It was good talking to you as well. Have a good day.
Bye everyone.
Bye.